Today we'll see management of open bite. We'll cover it under introduction, classification, etiology, then management. Then coming to what is overbite. I hope all of you know what is overbite. Overbite is a vertical overlap between uh, upper and lower teeth, especially in anteriors. When overbite increases, it becomes a deep bite, and when overbite decreases, it becomes open bite.
तो सॉरी टू डिस्टर्ब, आवाज बहुत छोटी आ रही है.
Okay. We'll repeat. Overbite is a vertical overlap between upper and lower teeth. When overbite increases, it becomes deep bite, and when overbite decreases, it becomes open bite. The normal range of overbite is 2 to 4 mm. Then, as per the glossary of orthodontic term, open bite is a developmental or acquired malocclusion whereby no vertical overlap exists between maxillary and mandibular teeth. Open bite is a term coined by Caravelli in 1842. Okay. Classification. It is broadly classified depending upon etiology as anterior and posterior open bite, and whether it is present in anterior area or posterior area, it can also be classified as anterior open bite and posterior open bite. Then coming to etiology, the etiology is broadly divided into hereditary factors and environmental factors. Hereditary factors are skeletal growth pattern, then vertical relationships of jaw, muscle dysfunction, and neurological disturbances. Environmental factors being tongue dysfunction, that is tongue thrusting or thumb or finger sucking, foul breathing, foreign body in mouth, trauma or pathology of condyles, or they can be iatrogenic factors and morphology and size of the tongue. Then dentoalveolar open bite. The extent of dentoalveolar open bite depends on extent of eruption of teeth. Supraocclusion of the molars and infraocclusion of the incisors can be primary etiologic factor. Supraocclusion here means excessive eruption of molar and less than normal eruption of incisors. Infraocclusion refers to less than normal eruption of incisors. In vertical growth pattern, the dentoalveolar symptoms include a protrusion of upper anterior teeth with involved inclination of the lower incisors. In horizontal growth pattern, pen postures and thrust may cause protrudation of both upper and lower incisors. A lateral open bite may be considered dentoalveolar in combination with the occlusion of molars. When class 2 vertical growth pattern open bite will be there, there will be protrusion of upper teeth and retroclination of lower teeth. And when class 3 open bite is there and tongue is large, then there will be proclination of both upper and lower incisors. Then skeletal open bite. Skeletal open bite is an open bite which is caused due to skeletal reason. That can be abnormality in one jaw or abnormality of the both jaw, where uh, dentals or teeth will be less involved or teeth will be near normal. Then in this picture, the cranial base angle and gonial base angle are obtuse. See, this is a normal occlusion, a normal overbite case, whereas this is an open bite, where the gonial angle is increased, as well as the cranial base angle also increased. See the cranial base angle here and see the cranial base angle here, whereas uh, the gonial angle is this angle. This angle is gonial base angle, gonial angle. It is increased. The same in this picture also. The long axis of the incisors from a small in open bite forms a small interincisal angle. Although the incisors are usually more extruded in open bite, this extrusion is not sufficient to establish their vertical contact. Then various treatment modalities of open bite. The first one is habit therapy. If there is any underlying habit leading to open bite, then it should first it should be addressed. Then appliance therapy. Then surgical management. The normal for habit breaking, we usually use tongue creep. Tongue creep is a removable and or fixed appliance. The clip consists of a palatal plate with a horseshoe-shaped wire clip. Anterior tongue thrust. In patients with anterior tongue thrust, we uh, use tongue clip to modify the habit and to treat the open bite. After using tongue clip, the tongue will not be able to contact the anterior teeth, so it will allow anteriors erupt and closure of the open bite. Then myofunctional therapy. We can use Frankel 4 appliance modified activator. These appliances incorporate bite blocks interposed between the posterior teeth, which gives an intrusive force on upper as well as lower posterior teeth. This is a modified activator where we can clearly see a bite block in posteriors, which is producing an intrusive effect on the posterior segment. This is a Frankel 4. The same thing is done here. The posterior uh, white block will put an intrusive force on the posterior teeth, while there will be no interference in the anterior teeth, which will allow their eruption and closure of open bite. Then orthodontic therapy. Mild to moderate open bite cases can be managed with fixed mechanotherapy in conjunction with box elastic. Then surgical correction. Skeletal open bite cases treated by surgical procedures involving maxilla and mandible. When a mild open bite case is there, we can treat it just with fixed orthodontic appliance and we can achieve their correction. But when severity is there, we need to go for surgical management. Or skeletal open bite cases, we need to do both surgery as well as orthodontic. Coming to posterior open bite. Posterior open bite is lack of contact between the posterior teeth when teeth are in centric relation. What are the causes of posterior open bite? It can be due to mechanical interference with eruption either before and or after the tongue emerges from the alveolar bone. Failure of eruptive mechanism of tooth so that expected amount of eruption does not occur. The treatment will be removal of cause and lateral tongue spike in order to modify if any lateral contrasting habit is present. Thank you.